Hi, everyone. Welcome to House Healthcare. It is Wednesday, March 22nd. And this morning, we're taking up H428, an act relating to prescribing by doctoral level psychologists. First, we have Representative Noyes with us, who is the sponsor of the bill. So welcome.
Good morning. Thanks for having me. For the record, Dan Noyes, representative for Wolcott, Hyde Park, Johnson, and Belvedere, along with Melanie Carpenter. Welcome. So a couple of years ago, I think it's been probably 4 years, I met with an individual from my community who brought this idea to me, and he really spoke about how this may be a really good concept for Vermont, as we're just trying to make sure that individuals who are interested or, at a point where they want to get into treatment have the ability just have the ability to have a relationship with somebody who can help who can prescribe Suboxone or a drug that will help them transition off of opioids. So the original idea was that, if somebody is already working with a psychologist and they are have built a relationship with them, a lot of times it's harder for them to go and start trying to get to another doctor's appointment. If there was just one point of access for treatment, we thought this might be a really good way to kind of build out the ability of people to get into recovery. They have that relationship. They're working with maybe working with an individual around their mental health and an opioid disorder could probably, be something that they could also help with. So when I met with my constituent at the time, who's since moved out of my area, we met about this, and he's worked with a number of individuals, but can't be their kind of primary person. So he's working with their mental health, but can't really deal with their physical health around being a prescriber. So he has that education level and thought this might be a really good way. It's the way that I guess it's done in the military and a bunch of other states as well. Do this so that, people can find a path to recovery. So sorry, I didn't really know I was going to be doing this morning.
No, I'm glad you stopped in.
Hey.
Honestly, we'd love to invite you. So thank you for stopping in.
Yeah. I was in government ops and in the past, and they requested a sunrise review on it in terms of for OPR to really look at it. And then put the bill in this year and it ended up here. I'd be willing to answer any questions I can, but I think Katie will also do a really good job walking through the bill. So,
questions for Dan?
So the bill is just intended to be able to prescribe like Suboxone?
No, you could prescribe other things, but that would be one that would allow people who are working with, a psychologist to be able to get treatment for their addiction.
So I guess
I think maybe these questions need to wait for to walk through the bill and potentially OPR.
Okay.
How's that?
Sounds good. Okay.
Anything else for Dan?
All right.
Great. Thank you
Thanks.
very much.
Thanks.
Thanks, Dan.
We'll just take a moment, stay on air while Katie comes up and sets up the computer to put the language up. Thanks, Dan. Good morning. We're taking a moment to introduce someone who he was on our healthcare committee 2020. Yeah, so former representative who was on our healthcare committee and was pretty darn amazing. Helped us with quite a bit. So welcome back.
Thank you. Glad to be here. I'm supposed to be representing downtown development, but I thought I'd come here instead.
All right, that was fast. Okay,
I was ready to go this time.
great.
It's already on Zoom. So good morning, Katie McGlynn, Office of Legislative Counsel. Welcome to our new
Thank you.
member. So before I start walking through the bill, sometimes I think it helps to step back and sort of get the big picture, the concept of what we're talking about. So what we're doing is we're amending the chapter on psychologists that's in Title 26, which is our title that regulates different professions. And this would allow for a doctoral level psychologist to prescribe. It's slightly more complicated than that because what this bill requires is that a doctoral level psychologist would have a collaborative relationship with the physician who's already prescribing certain medications. And under that collaborative arrangement, the doctoral level psychologist would be sort of working under the physician's prescribing license to be able to prescribe similar types of medications that the physician is prescribing, and would have regular check-ins with the physician to make sure, that there is sort of certain quality is being regulated. So that is the language that we're going to look at. So as I said, we're amending existing chapter on psychologists. The first section in that chapter is a definition section, and this adds new definitions. So first we have our collaborating physician. This means a physician licensed to practice medicine pursuant to chapters 23 and 33, so MD and osteopathic, who generally prescribe prescription drugs for the treatment of a mental health condition to the physician's patients and the normal course of the physician's medical practice. Drug has the same meaning as in the pharmacy chapter of this title. Then we have the prescribing psychologist. It means a licensed doctoral level psychologist who has undergone specialized training, has passed an examination, and has, as determined by rule, and has received a current license granting prescriptive authority under the new section of this chapter that this bill adds, and that has not been revoked or suspended. And then we have a definition of prescription drug that again is defined in the pharmacy chapter of this title. And lastly, the prescriptive authority means the authority to prescribe, administer, discontinue, or distribute drugs or prescription drugs. Okay, so then we have the powers of the board, meaning the powers of the Board of Psychological Examiners. And this adds a new authority in subdivision A5, which is to regulate prescribing psychologist licensees pursuant to the new section that's being added in section 3.
So I'm sorry, when you say the board, say that again, the board is?
The Board of Psychological Examiners.
Okay, thanks.
Okay. So section 3, this is adding a new section at the end of the psychology chapter entitled 26. And this lays out the whole program that would allow the licensure of doctoral level psychologists to prescribe. So first, we have that a psychologist may apply to the board for a prescribing psychologist license. The license shall be made on a form approved by the board and include payment of any required fees and be accompanied by evidence satisfactory to the board that the applicant has. So this is everything that has to be included in the application. There has to be evidence of the following: that the individual holds a current license to practice clinical psychology in the state. The person has successfully completed the following minimum education and training requirements, either during the doctoral program required for licensure under this section or in an accredited undergraduate or master level program prior to or subsequent to the doctoral program required under this section. And we get into what those specific educational requirements look like. First, on line 10, specific minimum undergraduate biomedical prerequisite coursework, including a class or proficiency in medical terminology, 2 semesters of chemistry or biochemistry with a lab, 1 semester of human physiology, 1 semester of human anatomy, 1 semester of anatomy and physiology, 1 semester of microbiology with a lab, and 1 semester of general biology for science majors or cell and molecular biology. Second, beginning on line 16, a minimum of 60 credit hours of didactic coursework, including pharmacology, clinical psychopharmacology, clinical anatomy, and integrated science, patient evaluation, advanced physical assessment, research methods, advanced pathophysiology, diagnostic methods, problem-based learning, and clinical and procedural skills. And also, at the top of page 5, line 1, a full-time practicum of 14 months supervised clinical training of at least 36 credit hours, including a research project during the clinical rotation phase. Students shall complete rotations in emergency medicine, family medicine, geriatrics, internal medicine, obstetrics, gynecology, pediatrics, psychiatric surgery, and one elective of the student's choice. The board shall set by rule program approval standards addressing faculty qualifications, regular competency evaluation and length of clinical rotations, and instructional settings, including hospitals, hospital outpatient clinics, community mental health clinics, and correctional facilities, in accordance with those of the Accreditation Review Commission on the Education for the Physician Assistant. I'm going to pause there just to say, when I was reviewing again last night, the physician assistant jumped out at me. This is the way the proposed language came to me originally. So I just want to flag it and confirm with OPR or the sponsor that that was what was intended.
Okay.
So we're still on our list of what has to be evidenced in the application. In subdivision C on line 12, that the person has completed a national certifying exam as determined by rule. And lastly, that the individual meets all other requirements for obtaining a prescribing psychologist license as determined by rule. And then in subdivision 2, we have that the board may issue the license if it finds that the applicant has met the requirements. In subdivision 3, a prescribing psychologist is only to prescribe prescription drugs pursuant to this section if the prescribing psychologist continues to hold that current license in the state, satisfies continuing education requirements for prescribing psychologists, including 10 hours of continuing education annually in pharmacology from accredited providers, and lastly, maintains a written collaborative agreement with a collaborating physician. That was part A, that was the application for the license. Now subsection B is the criteria for prescribing medication. First, we have that a written collaborative agreement is required for all prescribing psychologists practicing under a prescribing psychologist license that's issued pursuant to this section. In subdivision 2, the written delegation of a prescriptive authority by a collaborating physician may only include prescription drugs for the treatment of mental health conditions that the collaborating physician generally provides to the collaborating physician's patients in the normal course of the collaborating physician's practice. Then we have a list of exceptions of what can't be delegated to the prescribing psychologist. So that includes prescribing for patients who are less than 17 years of age or over 65 years of age, patients during pregnancy, and patients with serious medical conditions such as heart disease, cancer, stroke, or seizures, and with developmental and intellectual disabilities. And prescriptive authority for benzodiazepine Schedule III controlled substances. In subdivision 3, the collaborating physician is required to file with the Board of Psychological Examiners notice of the delegation of the prescriptive authority, and when a termination occurs of that agreement, that also has to be filed with the board, and the board will adopt rules for that process. In subdivision 4, all of the following apply to the delegation of prescriptive authority. So first, any delegation of Schedule 3 and 4 controlled substances shall identify the specific controlled substance by brand name or generic name, and delivery of a controlled substance by injection shall not be delegated. Delivery of Schedule 2 controlled substances shall not be delegated.
Hold on, Katie.
It's not a typo. You said Schedule 3 and 4, but it says Schedule 3 and B5.
I don't think it's a typo. I think probably I just misspoke.
Okay.
That's more likely. Thank you. But we can go, I'll go back and,
I'm sorry.
and check it against the original language. Yeah, thank you. Let's see. Subsection B, prescribing psychologist is not to prescribe narcotic drugs. And then in subdivision 5, a prescribing psychologist who writes a prescription for a controlled substance without having a valid and appropriate authority may be fined by the board for not more than $50 per prescription, and the board may take any disciplinary action needed. So fines and disciplinary action for prescribing without following the protocols set forth. And then we move to subsection C, which is what are these written collaborative agreements all about? So first, in subdivision 1, we have that the agreement shall describe the working relationship between the prescribing psychologist and the collaborating physician and shall delegate prescriptive authority as provided in this section. The top of page 8 specifies that collaboration doesn't require an employment relationship between the physician and the psychologist. But absent an employment relationship, the agreement cannot restrict third-party payment sources accepted by the prescribing psychologist. For the purposes of this section, collaboration means the relationship between a prescribing psychologist and collaborating physician with respect to the delivery of prescribing services in accordance with the prescribing psychologist's training, education, and experience, and collaboration and consultation as documented in a jointly developed written collaborative agreement. In subdivision 2, the collaborative agreement shall promote the exercise of professional judgment by the psychologist corresponding to that individual's education and experience. In subdivision 3, the agreement shall not be construed to require the personal presence of the physician in the place where services are rendered. Methods of communication shall be available for consultation with the physician in person or by telecommunication in accordance with written guidance that will be within the agreement. In subdivision 4, collaboration and consultation pursuant to an agreement shall be adequate if the physician does each of the following. So these are the responsibilities for the physician entering into these agreements. The physician must participate in the joint formulation and the joint approval of orders or guidelines with the prescribing psychologist and the collaborating physician. And the collaborating physician periodically reviews the psychologist's orders and services provided to patients under the order in accordance with accepted standards of medical practice and prescribing psychologist practice. Secondly, the physician provides collaboration and consultation with the psychologist in person at least once a month for review of safety and quality clinical care or treatment. The physician is available through telecommunications for consultation on medical problems, complications, emergencies, or patient referrals, and the physician must review prescription drug orders of the prescribing psychologist not less than monthly, including a review of laboratory tests as available. The agreement is to contain provisions detailing notice for termination or change of status involving a written collaborative agreement, except when the notice is given for just cause. Subdivision 6, a copy of the agreement shall be available to the board upon request to either the prescribing psychologist or the collaborative physician. Subdivision 7, so that nothing in this section shall be construed to limit the authority of the psychologist to perform all duties authorized under this section. In subdivision 8, the psychologist shall inform each collaborating physician of all collaborative agreements the prescribing psychologist has signed and provide a copy of these to the collaborating physicians, meaning that the psychologist can enter into more than one collaborative agreement as long as each participating physician knows. At the top of page 10, no collaborative physician shall enter into 3 collaborative agreements with psychologists. So the physicians have a limit of 3, but the psychologists do not. And then at the top of page 10, we have language about endorsements. So individuals who are already licensed as a medical or prescribing psychologist in another state may apply to Vermont for a prescribing psychologist license by endorsement from the state or acceptance of that state's examination if they meet the requirements set forth in the section and any related rules, including proof of successful completion of the educational testing and experience standards. Applicants from other states shall not be required to pass the exam required for licensure as a prescribing psychologist if they meet the requirements set forth in this section and related rules, such as proof of education, testing, payment of fees, and experience. In subdivision 2, it specifies that an individual has graduated from the U.S. Department of Defense's psychopharmacology demonstration project, will not be required to pass an exam required for licensure as a prescribing psychologist. The individual otherwise meets the requirements of this section. And in subdivision 3, an individual applying for prescribing psychologist license by endorsement shall be required to first obtain a clinical psychologist license under chapter 55 of Title 26. So they first have to have the clinical psychologist license to apply for the prescribing psychologist license. And then we have an effective date of July 1 of this year.
Thank you. Questions, Toppy?
My understanding is this person can't prescribe to people under 18 or 17 and over 65. My question is this: in that 14-month time that they have to be in a clinical setting, why do they have to have what do you call it? Obstetrics and then the geriatrics.
Yeah, I think.
Is that something that normally everybody does anyway?
It's a good question, and I can't answer that. It would be a better question maybe for OPR.
And I apologize if I have a question if I missed this. Does the physician get paid to do this?
This doesn't talk
Addressed.
about payment.
Okay.
It's not addressed in this language.
Okay. Leslie and then Melanie?
I just want to make sure I understand the language. So all those requirements is what are typical requirements, like you get a transcript and it's all shown on the transcript that they've accomplished this if you're already licensed, or you don't have to go back. So I'm just trying to understand that, and maybe you'll let us know.
I think that's a better question for OPR.
Okay, great.
Yeah.
So that's one question for me. I'm trying to understand all that. And I don't necessarily understand the over 65 part that Topper brought up, and I think that that's an important point. And I think that the language answers the question that I was pondering about. The psychologist is not an independent practice. They're collaborating. They can collaborate with 12 people and have all these relationships. Is that the model? Which is a really different model than, let's say, a physician assistant or MP or whatever. So this is a brand new kind of model.
So we're gonna, so hold that question.
Those are my queries at the moment.
Melanie?
Mine were along the same lines of just where those requirements came from, and is it being modeled after something like an MP model?
Yeah.
Just curious.
Yeah.
So we will bring up Lauren next if there's any questions for Katie.
I have a question. I don't know if you can see my hand.
Sorry, Mari. I'm sorry. Yes.
That's all right. And it's for the parking lot. And it sounds like Lauren's going to be coming out of the parking lot shortly to help answer it. I wanted to flag the use of the word narcotic because the current preferred term is opiate, and I know there are psychoactive medications that have a sedating effect, for example, that aren't necessarily opiate based, but just wondering about the rationale behind using the word narcotic as opposed to opiate.
So I will say that is the way the language came to me when I first put the draft together. I'm sort of thinking ahead that we have a definition of narcotic that we could cross-reference, and I wonder if that was part of the calculation, but I take your point and I will flag it.
Okay, thank you.
Great. Thank you, Katie. All right, next we have Lauren Lyman. I feel like we haven't had you here for a while, so we needed to bring you back.
Glad to be here. So for the record, my name's Lauren Lehman. I'm General Counsel at the Office of Professional Regulation. Not a problem. And I'm here today to talk about this prescribing psychology. So a little background first for folks. OPR regulates psychologists and their practice in terms of licensure in Vermont. So we have a board of psychological examiners. They review applications that come in. They set qualifications and establish regulations for obtaining a license to practice in Vermont. a couple of years ago, as part of OPR's charge, we're also charged with reviewing scope expansions and proposals for regulating new professions, licensing new professions, or even sunsetting, removing regulation of professions. And a couple of years ago in 2021, the House Government Operations Committee asked OPR to look at this proposal of expanding the scope of psychologists to allow them to prescribe medications. So in 2021, we undertook a scope expansion review in 26 VSA Chapter 57, very much specifies what factors we need to look at when we're considering scope expansion. OPR does that as an agency. We try to be unbiased and approach questions, novel questions independently, taking feedback from all stakeholders, the Board of Psychological Examiners being one of those stakeholders, proponents of scope expansion being another stakeholder, the legislature also being able to direct OPR to do these reviews. So in 2021, the House Government Operations Committee asked OPR to do a scope expansion review. Simultaneously, we also received a petition from the Vermont Psychological Association asking us to supporting a scope expansion and asking us to do this sunrise review or scope expansion review. And so that is where we are today. And we were doing it based on a proposal that was a bill proposed in 2021 and the structure at that time. So we were doing it on a previous version of this bill. And in that bill, and so that's where our review was. We have not yet completed that review. And that is for two reasons. One, OPR has gone through a significant transition in the last year, but also the bill changed. So there's significant changes in the bill. And so that needs some revisions for about half of our report. So that's kind of where we are procedurally right now. And I can give you, though, a glimpse into what our report is going to find, because we have done significant work, outreach, talking with stakeholders, public hearings, survey of the profession, looking at other states, because this is, this has been accepted in 5 other states, but it's been proposed in several others. There's other sunrise scope expansion reviews elsewhere. And we've looked at the data of uptake, access, and we've incorporated that all into the report. Right now, we're just trying to revise it to reflect the current proposal as we have staff coming on board. So that's where we are procedurally. Today, I can say that OPR the board supports, the board is still weighing in on this as well, so they'll be reviewing it next week. But the current version of the bill, 428, with adequate education and with the limitations proposed, the fundamental idea we don't believe pose a risk to the public. So with that very intensive clinical education, with limitations on populations served, with limitations on what medications can be prescribed, with that collaborative practice, it can be done safely for the public. That said, we think there's a lot of work that needs to be done, kind of with other policy considerations that aren't reflected in the current language. So we would like more time to finish the report to address those policy considerations. So some of those policy considerations, fundamentally, we ask, is it done safely or could it be done safely? Answer to that is yes, we think so, with these additional parameters, structure around it. 2, will the public benefit from this? It kind of goes back and forth. I think we've seen 5 other states have adopted this. The numbers of uptake of folks who have actually become licensed prescriber have been pretty low. There's a comparison, to psychiatrists. We have a limited number of psychiatrists in Vermont, but psychiatrists are not the only ones prescribing medications, psychotropic medications. Primary care physicians, APRNs, PAs are all prescribing as well. I think the benefit of having your psychologist do it is they're having a therapy relationship alongside of that. And so that's a definite benefit. So the population could benefit, although it's hard to see how much more. The other thing is, per capita, Vermont and New England have a pretty high rate of psychology and psychiatric providers compared to the rest of the country. That's not to say it's good. It's not to say that our workforce is adequate or there's not an access issue. It's just if you're drawing from a well, we're pretty high up on the water level right now compared to the rest of the country. Again, though, an additional provider could provide even more access. So it can be done safely, possible benefits for the population, additional policy considerations OPR would like to see addressed or would like to work toward addressing is when that pharmacology training occurs. The current bill has it proposed as being either part of the doctoral degree, undergraduate, or in a postdoc. That logistically for OPR can be challenging because we have to go through transcripts. We have to see, okay, was this course taken, and that can result in a lot of disputes. Was that course a course in biochemistry or a course in chemistry with some bioelements? You know, it can get very, it puts OPR in a place of being an accreditor almost, and it can be a challenging process. We have those in several professions, and it can be logistically challenging. It distinguishes between the bill proposed distinguishes between doctoral level psychologists and master's level psychologists. Vermont is one of 2 states that licenses master's level practitioners to be psychologists, full scope of practice. And it was a legislative intention that these 2 levels of education both be permitted to practice the same scope. This would be the first time we've deviated from that and authorized doctoral level practitioners to provide expanded services. The availability of training programs. So the model you see today before you, and I think maybe some of the language that Representative Cordes mentioned, is from Illinois. We like that model. We like their educational structure. We find that it provides that necessary protection to the public. But there are some nuances. Those programs are not readily available everywhere. There's some in Illinois. I think the closest one's in New Jersey. So they're hard to find. Regulatory oversight and funding. Right now, we don't have any prescribing psychologists in Vermont. This bill asks the Board of Psychology to regulate this profession. The model of OPR is that people with practice in the profession are regulating and providing guidance on how to practice. They're experts in their own profession. We don't have those experts right now, and we're asking non-experts to regulate a new field. Other states have addressed this by having kind of a co-regulatory structure with the Board of Medical Practice or other boards that have prescribers, maybe nursing. That's something we would want to explore further because it would be a unique model. And we don't know how it would kind of function practically. And then funding. Right now, the model is every license type or board funds itself. If we have we did a survey of our 700 Vermont licensed psychologists, had a 7% return response rate. 43 responded.
Oh my God.
80% of those 43 supported expanding the scope, but only 20 said that they would actually might undertake the education to become a prescribing psychologist. One already had the education. So we're looking at not a huge number of folks trying to fund a pretty intensive regulatory structure just for themselves. That could be costly unless we have an alternative kind of model thought through and established. There's some language issues with the bill. Right now, the prescribing authority is defined as prescribing, administering, they didn't use dispensing, but I think it's providing the medication. In our typical prescribing structure, there's a prescriber, but there's also a check. The pharmacist comes in and does the drug utilization review. They're the dispensers. Nurses might administer, but that's a separate function. So with each drug, there's the prescribing function, there's the administration function, there's the dispensing function. And
typically there's multiple healthcare providers in that system to ensure no drug interactions, it's the appropriate medication, et cetera. And so that's what we would recommend here is if you want to authorize prescribing, that's one level, but perhaps not dispensing. Maybe we consistently have the pharmacist dispense that medication. And I'm not sure what levels of, there's a prohibition on injection, but I'm not sure if administration would be something, that means actually putting the drug in the body, would be something a psychologist would be doing or need to do. I'm not sure of what medications that would involve. And then we've heard from many folks that it's a fundamental shift in the practice of psychology. So there might be a push once medication's involved that psychologists are asked to deviate from their main charge of therapy and behavioral modification and being pushed more toward a medical model of drug intervention. And there was concern that they're just two distinct functions and both have value independent of each other and shouldn't be, sacrificed or changed. The other things we would just, hope to see as we kind of work through this is, more coordination with Vermont laws. Again, this is an Illinois law, so I'm not sure how it would work with our medication-assisted treatment requirements for both federal and state level, how we've, if we're doing Suboxone from a psychologist's office versus being part of the MAT system and the wheel and hub and spoke. The bill refers to clinical psychology. We don't actually have a clinical psychology license. We just have a psychology license. And then also consistency with OPR's practice, the application structure, and making sure enforcement, we can enforce some of those things in the collaborative agreement. It might be challenging the way it's currently written. Our endorsement practice is different than what's reflected in the bill. And then the model, I think the model of practice is interesting too. There's discussion, in other states in that when the Department of Defense did this, was the initial trainer of psychologists to prescribe, and they were part of a team. They were part of a collaborative team of treatment providers to a patient, whereas our model of psychology is much more independent in Vermont, and you're not part of a team. So again, we generally support the concept. We think it can be done safely. We think there could be benefits to the public, and we still need more time to ensure that we have the proper policy supports in place to make sure that this is safe and functions and isn't too costly.
Thank you. Topper?
How much time?
Which time? I think we could have it this probably next month. End of next month.
So potentially an update before we leave.
An update before we leave. I think, honestly, if we were to consider something next session, we would be more than ready. So if this stayed on over the summer, we would be more than ready. I think we'd also like the opportunity, and I think it's only fair once we have the report, to give stakeholders a chance to read, review, and respond to that. If we did it by the end of next month, we wouldn't have that time for them to respond.
Mari and then Art.
Thank you. In Illinois or other states, do you know if workforce numbers were a limiting factor in how many collaborative relationships were able to happen? And do you see workforce as a potential issue in Vermont?
I'm not sure I know all of the answers to that. I know when it was taken up before, access was always a driving force behind it, was ensuring access to providers who could prescribe and titrate these medications, and also doing that hand in hand with a provider who was seeing you weekly was a strong benefit for it. The uptake was not significant. I have numbers here from their 2018 numbers, so they're not amazing. But they had, let's see if I can find them. So I'll find them some other time. I believe there's 5 states: New Mexico, Iowa, Idaho, Louisiana, and Illinois. And I believe it was somewhere, the maximum number, there's 2 states that hadn't fully implemented in 2018. The maximum number, I believe, was 50 in one state, and their populations are much more significant than Vermont. So that's what we used as a metric. I'm not sure obviously there could be disputes about causation, correlation, et cetera.
Yeah, I think it's, I support this. I think the requirements are really robust, and I'm just curious about how, if there's anything that we can do also to help if there is a workforce issue and we're prescribing, potential prescribing psychologists are having trouble finding a physician to help meet the requirements of licensing. And so something to think about for the future.
I think there's a good point. It was brought up, the physician's assistants is in there. The model of education is very comparable to the APRN physician assistant or a medical training. And so that's what was incorporated. In the Illinois law, they actually specify, in addition to physician's assistants, APRN or medical training. So I'm not sure if that's something we would want to incorporate as well.
Marty, are you good?
All set. Thank you.
Art?
Yes, thank you. And I apologize for coming halfway through your testimony. You might have covered it. In these other states, has anything gone wrong? Have there been any major hiccups with this process at all? Legally, or somebody got sick or something happened? Anything you've heard of?
I think that's a gap in our analysis right now. I need to reach out to those states to confer with them. From my understanding from the VPA, there have not been significant increases in complaints or any issues. Reimbursement is always an issue. This addresses it a little bit in terms of employment and payers, but I'm not sure. OPR doesn't look really much at the payer side of things.
The other question I have is, would a psychologist now want to be reimbursed more because they have that function under them and they've had to pay for all the additional training?
Yeah.
I'm wondering what that does with the fee structure of things. Will it up the cost of everybody's psychological counseling?
Yeah, an interesting question. I'm not sure.
Alyssa?
I'm just wondering, as the bill is introduced, if there's any concerns that you might have, or if it's been discussed in, formulating your report. I mean, the thing that stands out to me is continuity of care. And I'm not seeing anything in this that, that there's a requirement that this prescriber needs to communicate to other prescribers. I just know from experience, once you start getting like multiple prescribers, things start getting really complex with patients because they're all prescribing for different conditions. And there's not necessarily communication. And I'm not seeing anything in here about a requirement to, communicate to. Here in the state, we've been pushing for patient-centered medical homes. This isn't really part of that.
I think there's a couple of things in the bill that could address that. The collaborative agreement, you're working with that physician's patients theoretically. The other component, but I agree, one of the things that we would want to ensure is that psychologist is part of our prescribing system, the Vermont prescribing management system, prescription management system, and making reports to that system. And being brought into that system and that team of care rather than being an additional outlier. Right now, I think the benefits alternatively are you have somebody who is treating somebody's mental health who's kind of out there, and then you've got the prescriber, the primary care physician usually, or a primary care provider separately treating the medication. So you already have that kind of separation, and this is a step toward bringing them together.
And I'm also wondering about the requirement that they cannot prescribe, based upon number of certain medical conditions. Are these self-reported? Because patients aren't always really aware of what they have. The thing that jumped out at me was anybody who's pregnant. Well, you can go a long time without finding out you're pregnant.
I think the clinical training, the obstetrics, the geriatrics, all that would go toward recognizing and trying to train the professional to ensure that they're able to evaluate and determine whether it's appropriate to prescribe or there needs to be a referral. It could be dementia, or it could be a seizure or stroke disorder, or there's potential this person's pregnant versus, just doing, being out there without that training and that expertise.
Thank you.
Leslie?
So I think Alyssa brings up an important point about recording, where's the medical record? Is the prescribing recorded and communicated? Especially if you have a private practice, you have a collaborating relationship, but you don't necessarily communicate, or how does that work? And so I could see if you have 5 collaborating physicians and they all have different EMRs, that would be awful. So I'm not sure how that all fits together. So that would be a question of curiosity for me.
Yeah, certainly. And that continuity and collaboration.
Yeah, that connects with that.
Or if it's not self-reported, if it's in your medical records, all the psychologists have access to all of it.
Yeah, and they go to a different pharmacy. We'd love it if the pharmacy caught it, but what if, they go to someplace else? So it seems like there's an opportunity for problem. I would worry, yeah.
Papa?
You mentioned prescribing and dispensing, and you're okay with prescribing, is that right? But not dispensing?
If you think about it, when you go get a prescription from your primary care provider, you have to go to a pharmacist to dispense that. That's almost a check on your pharmacist. You might get a sample from your primary care, but you really should be going to a pharmacist to dispense it. When that pharmacist dispenses it, they look into a centralized system in Vermont and they can see what other medicines you've been prescribed. And so they can tell if there's going to be a drug interaction, if your medical record's been updated, they can, so we prefer to have that check and to consistently, especially in this situation where you're having a provider who is trained in psychology with an addition of prescribing, we would like another check on that.
So what you'd like in this bill
is
for it to say you can't dispense, but you can prescribe.
The authority would be for prescribing only.
So it sounds like we'll let you do your work.
Thank you.
We'll check in at the end of April, maybe for testimony, maybe not. We'll see where you are.
Yep.
We have next session to also bring this up. So, and I'm particularly interested as part of the analysis of what the costs are going to be to regulate this versus the projected uptake on actually the program being used. So I know it's hard to.
We'll throw some numbers together based on other states and what we've heard from so far.
Great. Thank you so much for your time and all your work.
Thanks.